Okay, so this is our third PowerPoint, and it's about differential diagnoses. Compared to normal grief, complicated grief is associated with prolonged distress and disability, negative health outcomes, and suicidality. So that's your review. People with CG have complicating symptoms or disorders that change the expected response to bereavement. We talked about it, that they may ruminate over concern related to death, cannot make sense of the loss, catastrophically misinterpret aspects of the loss, including their own reactions, and they may avoid reminders of the loss. Risk factors include lifetime comorbidity of mood and anxiety disorders, being female, history of mood disorder, low perceived social support, insecure attachment style, increased stress, positive caregiving experiences with the deceased, pessimistic temperament, personality correlates, and psychobiological findings, which were reviewed above. So, a little bit about complicated grief and depression. Depression shares common features with grief, and misdiagnosis can result in overlooking depression when it is present and inappropriately treating it as grief. So here's how it resembles depression. CGCAPS is our acronym. It resembles depression in all these symptoms: sleep, energy, guilt, interest, lack of concentration, reduction in memory, increase or reduction in appetite, increased psychomotor retardation. That means the person kind of moves slowly. Sadness, suicide, and decreased self-esteem. It differs from depression in its specificity. The sadness is related to missing the deceased. It's specific, it's not generic. Interest is heightened in memories of the deceased. So that doesn't change. There's an interest, continuing interest, a yearning for contact. Okay, and there's pleasurable reveries or memories associated with that. There's again increased concentration, and that's the rumination that's specific to the death or issues related to disease. And there's a preoccupation with positive thoughts of the deceased, intense yearning, and so on. And then you also still have all these SIGI caps, okay? But the difference is in specificity. Couple more comparisons. Complicated grief is not responsive to standard antidepressant treatments. There are different DSM-4 timeframes for depression and for complicated grief. The loss, you can find out that the loss triggered the depression. Complicated grief responds very well to support versus depression does not. Complicated grief includes overt, specific expressions of grief, of anger, much less so with depression. And grief guilt is focused on aspect of loss. It's not demoralizing or humiliating and is not preoccupied with the deceased. So at least 2 months post bereavement, 20% had major depression. And then 70% of those were not depressed, 70% out of the 20% at a 2-year follow-up. Versus for those who had 31 subsyndromal depression, meaning that their depression was not related to the grief, that rate remained steady at a 2-year follow-up. So there's more likely to see a resolution of the depression associated with grief over a period of 2 years, some by itself, a resolution by itself, rather than when you're looking at depression that's not related to the grief, but it's kind of comorbid to grief. Overall, it is thought that anxiety symptoms are more prominent than depression when we're talking about complicated bereavement, and they can be independent or comorbid. the differential between depression and anxiety that was found in literature is that depression is related to lack of positive events, versus anxiety is related to presence of negative events. And when you have both anxiety and depression, that cluster, each tends to be more severe. Other grief complications include physical health problems, feelings of neediness and loneliness, and there's a slight increase in mortality during the first 6 months, especially around the elderly. When the spouse or partner and they've been married for a long time, there's a risk for mortality for the surviving spouse within the first 6 months. I would say it's within the first year or two. Some of the treatment consideration are, this is a very nice quote by Brussier. It's a Gestalt approach. Change occurs when one becomes what he is, not when he tries to become what he is not. So there's a lot about acceptance. Treatment for bereavement and grief has to do a lot with acceptance therapies. Acceptance what is here because it is already here and we cannot change it. That's the most difficult thing about bereavement versus many other things that happen to us in life, that it's not reversible. And according to Saber, the tasks are to accept the reality of the loss, experience pain and grief, adjust to the environment, withdraw some emotional energy from the person that one lost and reinvest it in another relationship, and find a place for what we lose, what's called continuing bonds, to figure out how can we have a continuing bond with the person that we lost in a healthy way. All right, now we're going to compare CG and PTSD. PTSD, the criteria usually are for over a month. The symptoms have to be present for over a month in order to qualify for the diagnosis. So there's an exposure to a traumatic event involving death or serious injury. The response involves intense fear, helplessness, or horror. There's a re-experience, one or more symptoms, re-experiencing of what happened, an avoidance, 3 or more symptoms of avoidance, and increased arousal, 3 or more of symptoms, such as flashbacks. I'm not going to go over it in great detail. I think you're going to have a review of PTSD in your psychopathology course. But here's some of the interface of grief and trauma. The symptoms of CG are increasingly recognized as a separate stress syndrome that requires intervention. The term traumatic loss is event-focused and refers to a loss that is experienced from death taking place under externally traumatic circumstances, which may elicit shock, disbelief, horror, and helplessness. And there is evidence that such grief often remains unresolved over time. So traumatic grief, similar to PTSD, is more difficult to resolve than just complicated grief. And bereavement over traumatic loss then fits the clinical model of CG overall. Although there is some overlap in symptoms between CG and PTSD, and that's the intrusive thoughts, sense of futility, numbness, and so on, some of the core symptoms of CG are absent in PTSD, and that's the yearning, pining, searching, feeling a part of oneself has died with the deceased. Okay? And that's one of the ways to differentiate between traumatic grief and PTSD. Again, the specificity, just like with depression. PTSD appears to be a disorder related to the intensity or horror of a fear-provoking exposure. In contrast, CG can be conceptualized as an attachment disturbance, more a function of separation loss, anxiety, than of pure PTSD. And the primary, this is important, I know these are a lot of words that I'm throwing at you, the primary emotion is sadness, not fear. So depression, the primary emotion was sadness about loss. Here, the primary emotion is sadness rather than fear. Intrusive images are usually of the deceased or circumstance of death. The painful reminders more pervasive and unexpected, and nightmares are rare in contrast to PTSD. Again, the avoidance behavior is specific to the social situation, and dissociations are pleasurable because they revolve around memories of the deceased. And although there's a difference, treatment, just like PTSD, may involve reliving the moment of death and may be involving in vivo exposure to avoided situations, such as going into the room of the deceased. Here's some formal bereavement interventions. Interpersonal therapy, it's a specific type of therapy. Psychodynamic therapy, which is generic. Cognitive behavioral therapy. Brief group psychotherapy. Basic aids. Art and music therapy, and pharmacotherapy. Psychopharmacotherapy. Sorry, guys. It's a long PowerPoint to talk it through. So I know I said before that psychiatric medication seems to not help as much with bereavement as it does with depression. Nevertheless, it can take the edge off. And we have an issue with all these treatment that EST and EBT stand for evidence-based treatment. So we have an issue in the literature really suggests that group therapy, for example, which is one of the most common forms of therapy for bereavement, does not have empirical support. So there's no consensus as to best practice, and some of the reason for that is that there's too much theoretical heterogeneity, meaning two different approaches are too different to treatments, so it's hard to do a meta-analysis comparing the different kinds of treatments. Again, there's a larger inter-study variability, a lot of variability. There's not a lot of reporting of the intervention procedures, exactly what's being done. There's very few published replication studies and methodological flaws of study design, and there's ethical issues of doing control groups. So those are some of the problems that we have.